Welcome, everyone. We are going to go ahead and get started with today's webinar. Thank you, everyone, for joining us here today. My name is Melissa Morford, and I am a Neuro Resource Facilitator here with the Brain Injury Alliance of Iowa. Today's webinar is called Social and Emotional Aspects of Concussion. It's not just about the game, presented by Hannah Jepson, Laura Van Dusseldorp, and Ashley Job, all from ChildServe. This is our third webinar in a four-part webinar series regarding concussion management. I would now like to just go over a few housekeeping items here for this presentation today. As you can see on your GoToWebinar control panel, you will have two options to listen to the presentation. You can choose mic and speakers or the telephone option. If you're having any troubles hearing the presentation, just go ahead and try to switch out those two options. We will also be recording today's webinar and be posting it to our website in the following few days. To access this webinar, you can go directly to our website at www.biaia.org. Additionally, the PowerPoint slides should be available on your control panel for anyone who would like to print those out and use them here today to take notes. We will go ahead and also save a few minutes toward the end of the webinar for participants to ask any questions that you may have. You are welcome to type questions into the chat feature on your control panel, and I will go ahead and ask those at the end. No CEUs will be provided for this webinar, but a certificate of attendance will be emailed out at the end of the presentation. We will also be emailing out a link to our survey for participants to share feedback. I would now like to go ahead and introduce our speakers from ChildServe. First, we have Ashley Job, who graduated from St. Ambrose University with a BA in psychology and a master's in occupational therapy. She has worked in pediatrics for her entire career and specializes in brain injury and neurosensory motor primitive reflex integration. Ashley helped to develop the ChildServe Concussion Clinic along with the help of Laura Van Dusseldorp, Hannah Jepson, and Dr. Fred Kliegbiel. Ashley loves working with the wide variety of pediatrics seen in the ChildServe Concussion Clinic in identifying and treating visual vestibular deficits. The best part of Ashley's job is seeing improvements in the children she treats and getting them back into the academics and previously enjoyed activities. Next, we have Laura Van Dusseldorp, who graduated with a BS in biology from Simpson College and went on to earn her doctorate in physical therapy from Des Moines University. She has specialized in pediatrics most of her career with an emphasis on brain injury and seating mobility. Laura has worked over the past 3 years alongside Hannah Jepson, Ashley Job, and Dr. Fred Kliegbiel to develop the ChildServe Concussion Clinic. She works closely with the team to provide a thorough evaluation to determine the most appropriate path for reintegration back into academics, activities, and work. The ChildServe Concussion Clinic works closely with families, schools, and businesses to prevent long-term impacts and decrease the likelihood of another injury. In her personal time, she enjoys all outside activities and spending time with her family. Last, we have Hannah Jepson, who is a pediatric nurse practitioner that works with the pediatric rehabilitation medicine team at ChildServe. She performs inpatient brain injury consults in collaboration with Dr. Fred Kliegbiel in the Des Moines community local hospitals. She is a credentialed impact consultant and performs neuromuscular examinations on patients in the concussion clinic here at ChildServe. She works closely with the therapist on the concussion program with the goal of helping each client recover and reintegrate back into school and sports as safely as possible. We are excited to have Ashley, Laura, and Hannah with us here today to talk about how rehabilitation often focuses on a return to physical ability and classroom activities. Our experts presenting today will discuss the multifaceted approach and best practices for return to learn and return to play, including the social and emotional symptoms of concussion and ways to support a student's recovery in these areas. I will now go ahead and unmute our speakers and turn it over to them to begin their presentation. Can you guys hear me okay?
Hello all. Thanks for joining us today. We're really excited about this presentation. Very passionate about mild traumatic brain injuries and how we treat the kids of the local community. My name is Hannah Jepson. I'm the nurse practitioner that works with Dr. Fred, Ashley, and Laura. So today we are trying to flip the slide. Okay. Today, the presentation objectives include defining concussion, discussing a timeline for emergence of common symptoms, identifying what symptoms to look for or monitor during the acute phase right after injury, provide an overview for all of you of the stepwise return to academics and play, and also discuss the impact of concussion and the accommodations in the academic world. So concussion is in fact a traumatic brain injury. It is a complex process that affects the brain, which is induced by traumatic biochemical forces, which can be direct or indirect impact, where neurometabolic cascade results in improper cellular functioning. As I mentioned in the slide before, concussion or mild traumatic brain injury can be caused by indirect or direct forces. An example of these would be a direct blow to the head or the force of a body collision in football. A concussion can cause loss of consciousness or no loss of consciousness. And it's typically a functional disturbance in the brain and not structural. What I mean by this is that it does not show any change on imaging such as a CT scan or an X-ray. It is important to note that if another insult occurs while the metabolic state is still not back to its baseline, it sets the stage for another type of cellular death that can be catastrophic, known as second impact syndrome, which we will touch more on later. So factors that can complicate recognizing concussions is that the athletes may not recognize that they even have a concussion and are experiencing symptoms. The symptoms also may be delayed and not show up for 48 to 72 hours. And then also that the athlete may not be forthcoming about their feelings and symptoms that they're experiencing because of fear of not being able to play. And as I mentioned before, a concussion can occur without a blackout or their bell being rung, as many may know. So this is the average annual number of traumatic brain injuries in the United States reported from the CDC. The important thing to note on this slide is that the majority of the actual injured are receiving care outside of the hospital or no care at all, so the number isn't actually reported and we don't know an exact number. And it is important to let you all know that once you suffer one traumatic brain injury, you're 3 times more likely to suffer a second and 8 times more likely to suffer a third. This slide kind of breaks down the CDC TBI classification. And this slide is important to touch on because, as you can see, there's no specific section that's designated to sports-related TBIs. They all are integrated within these categories. For example, the struck by against category, that includes football. And as you can see, falls is the biggest leading cause of traumatic brain injury. So this is also important to note for parents and caregivers and people out in the community that this includes playground falls, this includes falls down the stairs, falls off a couch. So this is actually a lot more common than sports-related concussions. This slide touches base on the Iowa law here, which the Iowa law only pertains to high school sports. So some middle schools may enforce the Iowa laws regarding concussion, but they aren't actually required to. All schools have to distribute concussion information to athletes and parents prior to the participation, and then the school staff and coaches involved with school sports must receive some type of education, but it's important to note that the educational information for the community and the school staff is very minimal. And then the Iowa law states that high school students who is required to occur for high school students, not middle school students. The law states that any injured athlete/student cannot return until they're evaluated and cleared to play by a licensed healthcare provider trained in the evaluation and management and the concussion and other brain injuries. And then here it is important to note that as of now, anybody in the state of Iowa who is a healthcare provider can clear a high school athlete to return. So this slide discusses rates in high school sports of leading causes of the injuries. So obviously we'd expect football to be up there on the top of the list. Girls soccer is kind of surprising to see that falls close behind football. And most of these head injuries are caused by actual player-to-player contact when trying to head the ball. And recently, there's been rules that regulate the age of when soccer players can begin to head balls because of this. This is all based on high school sports, and there's very little information for middle school sports studies. So there was a recent study that was published that showed the incident rate for middle school soccer was 1.2 of 1,000 athlete exposures, which would surpass any of these that are on this chart right here. So how does concussions impact children versus teenagers versus adults? And recent studies are coming out with evidence that show the younger you are, the longer your recovery may take. You're more susceptible for a second concussion. You're less likely to actually be removed from the activity, and you're less likely to seek follow-up care with a physician or a specialist, and more likely to continue to play. Clinical features of a concussion, we have them broke down on this slide with in categories of physical, cognitive, emotional, and sleep. I was looking through this list earlier today and began starring the ones that I see most commonly in our clinic, and I was starring almost every symptom. So all of these symptoms are very common and we see regularly as providers in our concussion clinics. It is important to explain to you guys that concussion is only diagnosed and identified through the presence of clinical symptoms. As I mentioned before, you cannot take an X-ray or a CT scan and diagnose a concussion. So objective and subjective data related to these symptoms aid us in the diagnosis of concussion and also our treatment and management. So how do we begin to manage these symptoms? Systematic management of concussion is important in facilitating a safe recovery. So at the time of injury, you're going to be doing a sideline assessment and removing the student/athlete from play, and then identifying if the student needs to go to the emergency department versus following up with a primary care provider to be resting, providing symptom management, low, quiet environment, follow up with a primary care provider, and refer to a concussion specialist who can dive in a little deeper into the management and treatment of those concussive symptoms. The team approach really focuses on the communication between the specialist, the student, their family, and the school and coaches. And this is where a thorough specialty program really is beneficial, because we can all work as a multidisciplinary team to make sure that the athlete and student are being reintegrated back into academics and school appropriately and safely. So what symptoms are red flags for immediate care or urgent care, also known as the emergency department, would be if you see in the student or athlete unusual behavior, if you see vomiting, severe or progressive worsening headache, any type of seizure activity, the slurred speech, unsteady gait, any type of weakness or numbness in their extremities, and then altered what happened right prior to the injury occurring. Can they identify other people in the area, such as their coach or a family member? Now, I will turn it over to Ashley Job, our occupational therapist, who will discuss the social emotional aspects of concussion.
Hi, everybody. So I'm going to really dive into beginning with that team approach and kind of where you go from here when you have identified that somebody, in fact, does have a concussion. So this is a slide that I really want you guys to kind of get a mental important in managing the, and as you can see, there's kind of a surrounding loop of people that are going to help carry out the care throughout this entire process. So Hannah just went over the signs and symptoms with you guys previously and how a concussion is systematically managed. But it's important to identify everybody on the team that's going to help that individual through the process. So for instance, if it was a sports injury, then their trainer, anybody like that might be immediately involved in the management. If they end up going to the emergency department or to their primary care provider, they may help to manage, but may also refer on to a specialist in brain injury or concussions. Here at ChildServe, that consists of a physical therapist, occupational therapist, speech-language pathologist, Hannah Jepson, our nurse practitioner, and then, of course, Dr. Fred Klingbeil, our pediatric physiatrist. Throughout that process, then we make sure to stay in constant contact with the other people in this loop, like the teacher, the school nurse, school counselors, special ed teachers, anybody that is going to help that individual with a concussion continue to get better and manage their symptoms throughout the process. The one circle that I've not touched on there in the upper left-hand corner is psychology. So throughout this whole presentation, we are going to really touch on the social emotional aspect, in which case we might often get a psychologist or, again, the school counselor, school nurses on board to help with the social emotional aspects that they might be suffering from. So I just want to touch really quick on our concussion clinic here at ChildServe. So we have this map that just kind of indicates the different services that we offer. When somebody comes to ChildServe with a concussion, they will see our physician or our nurse practitioner for a physical exam. They'll do a neurological exam. They'll administer that SCAT, which is the concussion assessment tool that asks primarily about symptoms. It'll ask them to remember, different words. It'll ask them to say numbers backwards. It'll ask them to say the month of the year backwards, and just a bunch of aspects of memory. We also administer the impact test, which is a neurocognitive test. This is something really big that is wonderful because not only can you administer the impact test to get baseline results, especially for athletes who are at higher risk of concussions, but we can use it as a post-concussion tool, which gives us kind of a set of numbers based on different aspects of memory and cognition so that we can continually monitor their scores and see improvement. When they get into the therapy services side, we're doing a lot of vestibular treatment, looking at their balance, looking at their movement system, especially if they have signs of dizziness. We look at their ocular motor skills, so a lot of vision is impacted with concussions. Their balance and coordination can be impacted, and then we also work on a lot of physical conditioning when they get to the point of getting back to physical activity, and then constantly are looking at that cognition. As a team, we make sure that they are appropriately going through the stages to return to academics and return to any play or activity, and then helping with as many accommodations as possible. And then, of course, that last bullet is community, constantly staying in contact with any educators at the school, working on prevention, working on support if needed beyond what our clinic can offer. So the social emotional effects really are important because early identification and treatment is critical in helping the individual with a concussion kind of get back to their lifestyle that they once, had prior to this event. So if you think of a lot of these people with a concussion, their life goes from being what's their normal to now all of a sudden some catastrophic changes happen that impacts many, if not all, aspects of their life. So there's a lot of research out there about physical symptoms of them getting headaches and how you can manage those, but there's not a lot of research out there on the social and emotional symptoms and the management of it. So when they're first having a hard time remembering or concentrating on things. And what we do initially, which I'll get into in a little bit, kind of showing you that progression, is they're often told, well, you can't do this anymore, you can't do that anymore, you can't go back to your sport, you can't be really physically active right now, you have to let your brain heal. And when they're told so often that they can't do this, that, or the other thing, then they can begin to feel isolated, or that their life has changed so much that they can really start suffering from some of these social emotional aspects. So here's just a grid to kind of look at all of the aspects that can factor into social emotional effects of a concussion. The physical symptoms are, primarily the first thing that we notice if they're having a headache, if they're feeling dizzy, if they're feeling nauseous. If they're having those types of symptoms, then you can only imagine how difficult it is to get back into school, and their academic performance is now suffering because they have a headache so bad that if they're in math class trying to learn new subject matter or take a test, it's difficult, and now they're failing, or they're just not understanding what's supposed to be done. And they're falling behind, and that can be a really big change for a lot of these individuals. A lot of times they'll have difficulty with just the daily function and routines. Their sleep may be impacted, which we all know how we function when we don't sleep very well. If you put a concussion or a brain injury on top of that, now they haven't gotten a good night's sleep. They have to get up, they have to sequence getting dressed and doing their morning routine. Now they have to drive to school, and driving sometimes can cause dizziness or nausea. Now we're getting into school, and the school environment can be really difficult just based on some of the environmental aspects like the sunlight or loud noise or the crowds in the hallways. And all of these things continually factor in to them just feeling not right, or like they're kind of out of their element, and can continue to impact the social emotional effects of this. So I want you guys to keep a mental picture of this cycle because you'll see in future slides how specific symptoms or effects of a concussion can continually circulate, causing the social emotional disturbances. So I'm going to get into the specific effects now that you might notice of the individuals with concussion. And I just want you all to think about, many of the individuals we'll see have you know, all of these. Some don't have any, or some may just have a few of them. Since there isn't much research out there, many, if not most of the examples are based on cases that we have seen in our clinic. So if you go and search social emotional effects of a concussion, you're not going to get a whole lot of information. So all of these bullet points coming up are things that we have specifically seen with the clients that we treat here for concussions. We initially give that SCAT-3 that I mentioned earlier, which is that concussion assessment tool, which looks at symptoms. We have them rate the severity of their symptoms, and that's kind of our initial basis or foundation of what we work off of. We can really tell, you know, if they're having headaches or dizziness, it might be due to, you know, their vestibular, their movement or balance. So just going through some of these bullet points, increased anxiety. That's a really big one, because if you think initially somebody having a concussion, they're nervous to get back in school. They know that when they have to really concentrate or think really hard, even when they come to see us, that's what's causing an increased headache. And now they're nervous to get back into school because they are beginning to try and, you know, focus on the classwork that they're doing, and just by really trying to focus on that, it's giving them a headache, and now they're nervous to try really hard in class. The sleep changes. They don't sleep very well sometimes. They're either having a hard time getting to sleep, they're having a hard time staying asleep. We've had some children that have been in car accidents, and now they're having nightmares of it. They're thinking about it in the middle of the night, and if you can imagine, like I said earlier, just not sleeping and not having that time for the brain to heal can really affect and exacerbate a lot of these symptoms. We do see an increase in behaviors and outbursts. We've had a couple children in particular who, you know, they have a headache, and we recommend that, you know, you need to rest your brain. You go to the school nurse because throughout the day your brain needs to heal. And they're asking to go to these places, and maybe the teachers are asking them why or questioning them, or the teachers want to find out what's going on with them. And now they're nervous, you know, to get up in the middle of class when all their friends or peers are around them and leave class, or they're just feeling so isolated that they begin to have these behaviors and outbursts. The feeling of sadness happens a lot. Sometimes it can be described, sometimes it can't. And oftentimes when you really kind of talk to them more about it, it's due to just their life kind of turning upside down. They're now not able to hang out with their friends as much because being around the all the noise, or being around all these people, or going to a movie, or going on a ride with somebody can just exacerbate all these symptoms, and they're feeling sad because they can't do the things they once did. So the academic effects, this is a big one, because our primary goal in the beginning is not only to help manage the symptoms of the individual with a concussion, but first and foremost, we want to get them back into school. Research showed a long time ago that you wanted them to rest and stay in a dark room and sleep it off, but we found that that does not help. It actually helps to have the brain stimulated, but you need to constantly manage how much it's getting stimulated and accommodate as much as possible. So a lot of our accommodations come in this initial stage of just getting them back in school. So a lot of times when they do get back into school, they find that their academic performance is going down. They are maybe an A student. Maybe, you know, they're taking a lot of advanced placement courses, and now they can't figure out the simplest tasks. They can't take tests like they once did. Their grades are failing. And so that again leads to just the emotional aspects of everything. They're having to ask for more help. They need special accommodations that they once didn't, and they feel like they're being singled out. You'll see some of the accommodations that we recommend to help them, but for some of these students, even with those, they just feel like, you know, that they've changed as a student a lot. Some of the people that we see, they forget to complete their homework. It's hard for them to learn new information in a class, and then they'll avoid a lot of difficult work just because they're afraid of getting that headache. They don't want to focus a lot on mask because they know that when they really try hard at it, now their symptoms are coming back. So like I said before, we do recommend that they go to the nurse, especially if they're having any symptoms present, or even just to rest their brain for the day, or for a little bit of time during the day. So they're needing to go to the nurse more frequently. They're having a hard time remembering and concentrating. Sometimes just the sunlight alone or the noise in the class or people constantly moving around in the class can exacerbate those symptoms, so that sensory input can lead to some of that. So the main thing that I want to kind of keep in the back of your head is that bottom bullet saying that modifications at school are key to allowing individuals to return to academics but not become overwhelmed. So we'll kind of get into here in a few slides of specific accommodations. For a lot of our teenagers, or junior high and high school children in particular, these social effects can really impact the way that they're feeling. So just even having a decreased interest in once enjoyed activities. We've had people come through who loved to read before this, and now they just don't even feel like reading. It's not that important to them, or they're not wanting to hang out with their friends because all that sensory input, maybe their friends want to listen to loud music in the car, or they want to go to the movie theater, or they want to go outside on a sunny day. And sometimes that light, that noise, and all the other types of sensory input is just too much for their brain to handle. It overstimulates it. It causes those symptoms that we looked at earlier. We've had some people come through who, maybe their girlfriend or boyfriend has broken up with them because they say that they're acting differently. So on top of your concussion and on top of not feeling like yourself, now others are noticing you're not feeling like yourself, and we've had people who've gotten broken up with because of it. So you can only imagine now how that will impact your social and emotional effects of this. So they might have fear of losing friends because of it. And the biggest one, again, is at the bottom, the isolation of being told that they cannot do certain things that they once were able to. I think the biggest thing to explain with this is that, especially with an athlete, for instance, you take an athlete who is with their team often. They're constantly practicing with their team. They are able to lift weights, and they're able to get back into practice, without any difficulty. Say they sprained their ankle, they're still able to practice and do things with their team. But when you have a concussion, you want to limit the stimulation to that brain, and so they're being told, you need to rest a little longer before you go back to this. You need to rest a little longer before you go back to lifting weights. So they really feel isolated sometimes, which is something that's really important to keep in the back of our heads to allow them being able to do as much as they can without exacerbating those symptoms. They may feel like they're no longer an active member of their team because of that, or they may be missing the big game. We have somebody right now who has one game left. It's the last game for a team he's been playing with for, I think, 6 or 7 years, and he's just not ready to get back into the game yet, especially because it's basketball, and if he got hit in the head with a basketball, then we could be looking at second impact syndrome or something that we'll talk about later at the end. So again, on the bottom, their modifications are really key to allow somebody to return to their sport also or other activity without exacerbating symptoms. Okay, sorry guys, we'll catch up here. So now what? So now that we're more aware of the social emotional effects that can impact somebody who's had a concussion, we want to help them return to their previous activities in a safe and systematic way, starting in academics and then getting them back into play. So accommodations are key. So when we see somebody, our first goal, like I said earlier, is to return them to academics. We want to get them back into school. We often, depending on the severity of their concussion, may start them part-time, but we want to get them back to going to school full-time if possible, just working on accommodating them as much as possible. Here is something that we give to somebody who comes in here who's had a concussion, just to kind of not only help the child and the family see where they're at and where we want them to be, but also this is something that we send to school nurses so that they can distribute it to the school staff to see the recommendations that we make and the accommodations that we recommend at that point in time. This is something that you can find in a lot of literature out there, or at least, similar stepwise approaches. We are finding that, we've used this since we've started our program here, but we need to add more social and emotional aspects to this. Our speech-language pathologist is somebody who really helps get the child back into academics, especially when they're struggling with more of like the memory, concentration, focus, attention aspects of their concussion, and has found that, when we go from sending somebody back part-time with moderate accommodations and then going back to full-time school with minimal accommodations, it's not enough. And we're finding that we need to actually increase those accommodations sometimes when they're going back full-time so that they can be successful, because success is what ultimately is helping them get through some of those social emotional aspects that they are dealing with. Once they are getting back into school and they are, maybe managing their symptoms enough where there's not an increase in symptoms, we start to work them through returning to play. And that could be as simple as returning to recess or being able to run around with their brother or sister, and then for some of our athletes out there, safely getting them back into playing their sport. This is similar to the stage-wise approach we just did, but this is returning to play. And something that's really important to kind of look at here, especially for those coaches, athletic trainers, or athletic directors out there, is that we don't want to overstimulate the brain too much. We want to work them through these stages where first they're doing minimal activity. Sometimes alone, somebody who lives in a two-story house and walking up the stairs can increase symptoms. That minimal activity. So we want to make sure that with minimal activity, which is stage 1, or even light aerobic exercise, which is stage 2, that they're able to do those things without an increase in symptoms. Because again, that's how really you can manage their progress, is just by going back to that symptom management. So once they're able to safely, walk and go upstairs without symptoms, then we'll move them on to stage 3. This is where we're adding in movement. If they play a sport, we're doing more sport-specific exercise. So this may be where they're doing dribbling drills in soccer. This may be where they're able to get back into running. Maybe they're running at an incline on a treadmill just to kind of get their heart rate up a little bit, but nothing more than that. This stage is really focusing on getting their heart rate up and seeing how they do with just that alone. So we're not adding anything else in other than when we kind of move on to the next stage, which is stage 4. When we get to stage 4, if they're an athlete, this is when they can start doing kind of more complex training drills. In our program, this is when we will start doing resistive training. So obviously when you're doing some resistive training, your breathing changes. You can sometimes hold your breath a little bit more, which increases the pressure in your head, and that's why we wait until they're into this stage to start that resistance training. This is also the stage where we may have them start doing more jumping around, jump ropes, jumping jacks, something where they're having more impact, because again, a concussion doesn't have to be a blow to the head. It's just that brain moving around and that cerebral spinal fluid and possibly hitting their skull, which can cause a concussion. So in this stage, we get them jumping around, which is jostling that brain a little bit more, and see how they're doing and feeling during and after this. And this is also the stage where we begin getting their head below their heart. So we may have them doing burpees in this stage. We may have them doing just planks or push-ups. When they can do all of that and tolerate all that with an increase in symptoms, then we'll move on to full contact practice and then return to play. I've had people come through who are wrestlers, and we have worked on like takedowns and getting them, throwing them into something cushy, but making sure that they can handle that impact without an increase in symptoms. So now that you guys kind of see the importance of using that stepwise approach to get them back into full days of school, and that stepwise approach to increase their activity level to get them back into play, I just want to talk to you about some accommodations that we often make. So when we send somebody back, you'll often see that we start with an abbreviated class day schedule. This may mean that they're only going for half days, they may be going every other day, and then letting us know how they do with that and what areas they're struggling on so we can further accommodate them. We often don't send them back to physical education class or may recommend modified PE. And modified just means, you know, nothing that puts them at risk of falling or getting hit in the head and putting them at risk of yet another concussion. And that would be the same for modified recess. We often consider, you know, makeup work as critical work only. Sometimes these kids are going part-time school long enough, they're falling so far behind that then when they do start getting back into school, they're expected to make up everything and falling even further behind and not able to understand the new subject matter, which leads to, of course, a lot of other social emotional aspects. As far as testing goes, we do ask that they don't do any standardized testing just because their scores could be impacted due to their symptoms. We often ask that they're provided extended time to complete assignments, extended time to take tests, often a quiet environment to take tests, just because a lot of that sensory input can make it hard to concentrate. And then some of these others, you know, we often ask that they're provided class notes or able to use notes to take tests because a lot of the kids we see just have a lot of memory or concentration difficulties that kind of gives them an unfair advantage for that, for taking tests and doing well. As far as the physical accommodations, this is primarily just due to symptoms like headaches, dizziness, nausea, and fatigue. So we often tell them that they need to visit the school nurse if they're feeling these, because anytime they begin to experience these symptoms, that's the brain's way of saying, hey, you're doing too much, I need a break. And when they're experiencing these symptoms and quote unquote dealing with it, their brain's not healing and it's going to take them even longer to recover from the concussion. So visiting the school nurse, taking rest breaks throughout the day are huge things that we often recommend. I think that one of the biggest areas that we all need to really keep in mind with anybody who's had a concussion is the social emotional aspect that we often do not uncover until we've asked about it. So daily check-ins with the student are recommended. Often we ask about, you know, sadness, we ask about you know, if somebody's more emotional or more irritable. With, you know, do you have feelings of hurting yourself? And throughout this with, you know, I can think of 3 cases you know, alone that, you know, they have. And we would have never known that if we hadn't asked and never knew that things were as difficult as they were because we hadn't asked. So please check in daily with the students. This could just be on symptoms. This could be on concerns of, you know, how they're doing or if they feel like they're falling behind or other ways that you can help. And then sharing progress with parents, school nurses, that whole team that I told you guys to keep a mental picture of before, that whole team. It's really important that everybody's on the same page and coming up with a plan to really make sure that the individual is successful in getting back into their daily routine. So developing an emotional support plan with the student, especially just identifying somebody that they can talk to if they're feeling overwhelmed. Often when I talk to some of the people who are really struggling, it could be their guidance counselor, it could be a school nurse, it could be a friend, just really helping to identify that because we do see a lot of sadness, depression, anxiety with these individuals, and that is normal for a concussion. So it's really up to us to help them figure out how to cope with that. So I touched a little bit on sleeping before and just how important it is to get a good night's sleep because that truly is the only time for our brain to heal. So just some recommendations we often make if somebody is struggling with sleeping is avoiding the caffeine, limiting naps if they're in the early stages of a concussion where they're not yet back at school, really keeping that nightly routine and limiting screen time before bed. And a routine is so important. Waking up at the same time every day, eating your meals at the same time, going to bed at the same time, showering every day like you would, keeping those typical routines they once had are so important to helping them kind of get back into that natural routine. And then we obviously want to look out for any new onset or or worsening of symptoms like depression. We do a depression screening here for teens. If we do identify that they are struggling with depression, we may put them on kind of a low-dose SSRI or refer out for psychiatric evaluation. That's why that team approach comes in handy with really keeping that in the back of our mind, because we can't do it all, and there are things that we need to identify when we need to refer them out more for psychiatric evaluation, or just recommending that they go talk to somebody if they are really struggling with the social emotional aspect. So just kind of wrapping up the social emotional piece, building trust and rapport with the individual is key. Making sure that you're talking to them, listening to anything that they have concerns about, really working on educating about the injury. Like I said before, the sadness, the depression, those are normal parts of a brain injury. The identifying misinformation, you know, a lot of people often compare somebody's concussion to somebody else's. You know, everybody's concussion is different. We might think, well, so-and-so, you know, didn't have such a hard time sitting through class. Why are you? So really remembering that everybody's concussion is different, and that all aspects of their concussion don't take necessarily kind of the same road to recovery. Really preparing the athlete and coach about the recovery process. So maybe they're, you know, instead of isolating them, we're getting them back on the sidelines and getting them into practice, building in the activity, and then really encourage the use of coping skills, helping to talk with them about setting goals, whether that's, you know, today you're going to get through fourth period, you know, for at least 20 minutes before, you know, you have to get up and walk to go get a drink to kind of get away from the stimulation, or whatever it might be, just setting little tiny goals so that they can begin to feel like they're really improving and taking those small steps needed for recovery. Since mental health is such a concern often with concussions, we do want to often, you know, look at what we can do for them if they're experiencing some of the symptoms like sadness, depression, irritability, or just feeling more emotional. So the depression screening, again, is something we use, looking for, you know, if you're noticing these substance abuse problems, continuation of symptoms beyond what is expected. So on average, we look at between 21 and 30 days as average for recovering from a concussion. That's the average amount of time it takes for the brain to heal if we're doing everything right and not overstimulating our brain. So after that 30 days, if they're still having symptoms, we want to dig a little deeper into how else we can help beyond the typical, you know, accommodations. You know, maybe they need that referral for a mental health specialist or a psychologist. You want to look for disengagement in activities or people that they once hung out with. If they're having excessive anger or rage, frequently crying or being more emotional, and then that feeling of harming themselves or others. A lot of kids that we see have recovered from the physical symptoms, so maybe they're not feeling that headache or that dizziness anymore, but they are still experiencing these social emotional aspects, especially in school. They're having a hard time remembering things. They feel like they're doing more poor on tests. They're unable to concentrate and learn new subject matter, and that alone really impacts that social emotional well-being. So it's important to ask them, you know, daily about how they're feeling, and then really refer out if you have any extra concerns in these areas. So I talked about that duration of 21 to 30 days as kind of the average for the brain to heal, an average amount of time that we see people in our clinic for getting them back to kind of that full stage of school and that full stage of play. If somebody has symptoms that are present 3 months or more, this is known as post-concussion syndrome. You know, after 90 days, they're still experiencing these symptoms, and sometimes it can just be, you know, sometimes somebody may not, you know, have that big of a problem until all of a sudden it's 3 months out and now they're starting to experience these, and it was just the right amount of time for them to realize, you know, or to get in to see a doctor that, wow, you're in that post-concussive stage and now we need to kind of take a look at making those accommodations and getting you back into your once enjoyed activities, because this is something that means that the brain has not fully healed and something that we need to be really sensitive to if they are in this post-concussive stage. Causes for this can just be due to damage of the brain. It can be related to a lot of the aspects such as headaches, dizziness, some of those that you can see listed out there. Hannah had said earlier there are no tests available for a concussion. There's nothing that says you have a concussion other than talking about symptoms. So a prolonged presence of symptoms can really affect the individual, and we really need to, again, just be looking at those accommodations and how we can help them get back into their daily routine safely and without making them worse. Coping techniques are huge, especially at this point in time, and sometimes multiple concussions can lead to this post-concussive stage. You know, we see people who've had a second or third concussion, and now we're noticing that their symptoms are lasting into this post-concussive stage just because they do seem to get worse with time. So the big question becomes, how many concussions is too many concussions? There's really no evidence out there that says, you know, once you have 5 concussions, that's it. It doesn't work that way. It really is, you know, based on the individual, but some factors to consider there are second impact syndrome, which we talked about earlier and said I would talk about more at the end here. So second impact syndrome is something that you really need to be careful of, especially for those who are getting these individuals back into sports or back into physical activity. Second impact syndrome is when you sustain a second concussion before your first concussion is healed. If that happens, that's when you've been hearing in the media a lot lately of really those long-term effects from it. That's when you've heard of CTE, or the chronic traumatic encephalopathy, for people having these multiple concussions on top of concussions. Maybe they're not fully healing before they have a second one, and this is where, I mean, obviously worst case scenario, somebody could die from it. So you really need to make sure that you are helping the individual safely return, you know, and using a stepwise approach, because the biggest concern, again, is the second impact syndrome. If they've had multiple concussions, it's often important to talk to them, you know, about priorities, and if they truly, you know, if football or baseball or, you know, basketball, soccer is the most important thing in their life, because they could be at risk for, you know, some of these lifelong impacts. But the main way to make sure that somebody is able to continue doing what they love and moving on is really just to work on that timeline. Don't rush anybody back into anything, you know, too soon, and really work through that stage-wise approach. So speaking of some of the sports, helmets do not prevent concussions. Helmets are a great way to prevent skull fractures and more of those type of injuries. That's what they're for. Concussion does not need to be head-to-head impact, remember. So you need to use safe techniques. You need to enforce rules. Studies show that if an athlete is under stress, they're more likely to suffer an injury because they're more distracted. The best prevention is to modify these unsafe techniques. So spearing in football or body checking in hockey, teaching the correct techniques. So, you know, teaching correctly tackling, or correctly doing some of these things that often lead to a concussion. So after all of that, we'll just go through and re-review our objectives here. Hopefully now you guys kind of know what a concussion is, the timeline for emergence, the signs and symptoms to look for. Monitoring them throughout this is key, and then really working on that stepwise return to play or return to learn to get them safely back into all of these once loved things. And then really working on accommodations to help them through this difficult time. So at this point in time, we can open it up to any questions and go ahead and answer. I know some of the other girls here have been looking at questions and talking about answering them, so we will get into those now.
Melissa, do you want to ask and field those, or how do you want to go
Yep,
through
I'll
those?
go ahead and ask them, and if you guys
Okay.
will maybe just go ahead and answer them. I'm going to start with our most recent questions here. So the latest question we have in regards to return to play, our audience member is finding that female athletes are having more frequent and longer lasting recurrent symptoms after progression past light aerobic activity. Some research the audience member has looked at does not show or does show that sex could have an impact on recovery timelines. Have you seen anything like this in the clinic? And would you suggest another moderate aerobic activity or tailoring a return to play progression based on the length of symptoms after initial injury?
So I'll talk a little bit about the aerobic phase. I cannot say for sure that I've seen anything in regards to symptoms lasting longer. However, I will touch on, maybe they just need to stay in that phase a little bit longer before progressing them on.
There is research out there that say females may take a little bit longer to recover sometimes. But yeah, like Ashley said, we haven't really seen that necessarily in our clinic. It's kind of been, all over the place just because of how individualized each of the kids that we are seeing are. So as far as tailoring their return to play progressions, like Ashley said, it's really individually based, gender aside. Sometimes it does take longer. Those kids might be stuck in maybe stage 3 or 4 a little bit longer, or they might have to back down to stage 2 where you're really just kind of challenging them cognitively and visually before you're really starting to get some of that physical activity back in there. Does that kind of help answer your question?
They don't really have the ability to respond, so we'll assume that the question is answered unless they note otherwise here. So I'll go ahead and move on to the next question, though. Regarding academic accommodations, is there a specific form schools could share with the primary care provider in which the primary care provider could give guidance and have direct input to the school and return to learn? There are several good recommendations on this presentation, but the audience member feels something along the lines of the Iowa Sports Return to Play clear guidelines would be beneficial for schools to have if they were specific to return to learning. She just didn't know if Child Serve offered something for schools or some sort of example to use. Can you guys hear me okay?
Yep, can you guys hear?
Yep. Did you get that question?
Okay. Yes, we
did. Okay.
We do have a form that we share with the whole team on our recommendations and different accommodations for returning to academics. In general, I know the state of Iowa has gathered a lot of interested parties through the support of the Brain Injury Association, and they're looking at developing a full system of return to learn. And focusing more on that return to learn. So you've definitely identified a need within our state.
Yep. And I'll go ahead and comment too on behalf of the Brain Injury Alliance of Iowa. We're still very much in the development phases of a potential concussion protocol that we would share with the different settings like a school. But as we have information, we will definitely share that with our email listserv. So.
And Melissa, I think to go along with that too, somebody had asked about the return protocols that we use too, and so that's a good thing to bring up is that everybody's kind of working on a more standardized tool to use. Ours, we've just adapted from the Zurich statement from 2012, and it's actually on the bottom. If you look on those handouts, you can actually see there's a website that you can go to that connects you to the Zurich statement. The CDC also has a bunch of really good return to learn, return to play. It's kind of the consensus is all the same in how you're stepwise returning them. We just took them and kind of adapted them to what we've been seeing. And, ours are ever evolving too. We're actually going to be making some changes to kind of catered around to more what we're seeing. So I think that is definitely an area where everybody can improve on. And I think it's going to be really great once we can kind of come to a more group consensus then.
Great, thank you.
Yep.
Okay, so the next question we have here from an audience member is, what is the best medical treatment for headaches associated with it?
Hold on, we're going to hand that over. Oh, yep, we'll hand it over to Hannah real quick. I think the big thing that I'm finding when I'm hearing a lot of complaints is headaches is you have to
figure out what's going on in the environment and really talk with the student or athlete and help them to identify when the headaches are coming. So, and kind of keep a headache journal. So that's where I start before any type of prescription. I work on a headache journal and helping the children and the family to identify what might be aggravating headaches or causing them to even the onset of them. So whether it's school, too much screen time, too soon in activity, reading is a really big one. The visual motor tracking of reading can cause headaches. So we try to work those out first. And if we're still having trouble, at that point I recommend over-the-counter medications. If there is a child with a concussion in conjunction with a brain bleed, you should not recommend ibuprofen because it's a blood thinner. So I always, just to be on the safe side, recommend Tylenol every 4 hours as needed. If we're still modifying and making accommodations in the environment and with behavior, and then have the Tylenol on top of that, and they're still having ongoing, consistent, persistent headaches that are rated, I would say, you know, greater than a 5/10, I will prescribe Imitrex or naproxen, but I usually do a very short-term dose and just really have them try the Tylenol and behavior modifications before that. So I would say I'm not quick to prescribe headache medication until we've looked at all the other aggravating factors and other alleviating things we could do.
And sorry guys, I never did introduce myself. This is Laura, the physical therapist. So some things that we like to do too is that we'll refer on to massage therapy, a craniosacral therapist if there's somebody who's really someone who's really trained in that. We've also had a few kids go to an OMM and have, you know, just gentle manipulations and things like that, and those all have really helped. Oh, and then one thing, you know, that we're kind of looking into is light therapy too. We send some kids to Cedar Rapids out there for light therapy because they have all the equipment out there. But so there's some other options that, you know, after, either before or after, if we decide medicine isn't the first route to go. We've had really, really great results though with just general, you know, massage and all that, and just relaxation. Those have really helped cut down with the headaches.
All right, good deal. Next question here. Do you have a direct link to the graduated return to academics? And then the next question is, do you have any outreach for the more rural areas in the state of Iowa, or do families need to travel to Des Moines to receive services through ChildServe?
Yep, just to kind of go over that, the direct link, we don't have those up yet. We're still working on ours, and like I said, it's kind of a consensus in the whole community just to kind of get a more standardized tool to use. So again, you can look on the CDC. Melissa, you said you guys are kind of working on that too, and then also the Zurich statement. They all have pretty standardized tools. We've just made ours, you know, more ChildServe looking, I guess, and we've just kind of adapted them. So that's where it's the best area to find those. And then as far as, let's see, what else is there? Oh, as far as helping the rural. So right now, that's kind of our next step in our clinic is to do a little bit more rural outreach and start helping those rural communities. In our talks that we've had, other talks that we've had, I know that's a huge, huge need because you guys out in the rural communities don't have the type of equipment and settings that we do here. And so right now, we have had families travel from the outer reaches of Iowa to come see us, and then we work directly with those more rural schools. So that's definitely something that we acknowledge is a need, and so we're working on that. But yeah, right now most of the rural kids, they're traveling to come see us maybe for a one-time appointment and follow up. We've had a kiddo come from Algona, and she came, what was it, every week, just one time a week, and we've had some kids come from every other week. So we've had where we do more of an outreach program and work with the schools up there and the families and do a more, not abbreviated, but more accommodations to our treatment schedule than what we usually do here.
Okay, good deal. Last question or comment here that I have. One of our audience members commented that the Iowa concussion law covers all athletes from 7th to 12th grade. And I think you guys may have commented that it was for a high school. I didn't know if you guys had any clarification or wanted to direct anybody to a certain location for that information.
No, yeah, thanks for bringing that up. Yeah, that's something that we didn't catch, and it's definitely, it is, the Iowa law does pertain to 7th through 12th for school-based activities, but it doesn't cover some of those club teams. So yeah, thank you for pointing that out.
Good deal.
And Melissa, I know there was another question too on other assessments that we use.
Yes.
Yeah, the SCAT-3 is a really great sideline assessment tool, and then we still kind of use it for the cognitive piece. What's it called? The symptom severity, just to kind of watch their progression through. So we ask that frequently throughout our treatment. We use the scale because it kind of gives the actual objective number, and it really helps us kind of see, are their symptoms getting worse, kind of staying the same, or how it's going. We use, like Ashley said, we use the impact test. We have the Dynavision, which is more challenging for our eyes and gives us some more readouts there. We use just your general balance assessments, so maybe your best, your modified best, single leg, tandem, eyes closed, and then also we use a vestibular ocular motor screening tool to kind of see how their eyes are functioning and if it brings out any symptoms or not. So those are kind of the assessment tools that we use, and it just it helps kind of weed out, and it gives you some really good objective data to use to see how things are progressing.
All right, good deal. And one last question I think popped up here. The question is, what is OMM or OMN?
Oh, it's OMM. It's osteopathic manipulation, basically. So it's kind of similar to chiropractic, but it's not as, I guess what's a better way of describing it? Yeah, it's not. I would say it's not as aggressive. So with OMM, it's kind of similar to your craniosacral, where it's more feeling where you are in alignment, and you're not looking for that pop necessarily. You might be using more muscular techniques to get things to come back in alignment. So it's not as aggressive as your chiropractic techniques. We've had quite a few kids go through chiropractic treatment in conjunction to our treatments, and we really haven't seen any benefit to that, to be honest. Because really what we're dealing with, people are out of alignment probably, but right now it's not really helping with their headaches and things like that. You have more tension, more muscle tension. So OMM and massage and craniosacral, those will kind of address more of your muscle issues. And then down the road, if they're still feeling like, gosh, my actual neck is bothering me, then people have gone to chiropractors. So really, if you address more the muscles in the beginning, that's where you're going to see better symptom management with headaches, just tension in the neck. You'll see a lot of kids, they complain that both sides of their neck hurt, so that's, more your trapezius than it is your actual spine. So if you address more of the muscles first with the OMM, so that's just more general muscle techniques. Most osteopathic doctors have been trained in OMM, so like here in town we use Des Moines University. They have it's an osteopathic medicine school, so I don't know if a lot of rural communities have DOs, so that's kind of a way. Yeah, and like I said, massage is always a great thing to prescribe, so.
All right, good deal. I'm going through questions here. I think we've got all of them covered. So we will go ahead and maybe just wrap things up. If any of our audience members have any additional questions, you are more than welcome to contact us here at the Brain Injury Alliance of Iowa. Our general email is info@biaia.org. But otherwise, Ashley, Laura, and Hannah, thank you very much for sharing the information with us here today. We really appreciate your guys' insight on some of these concussion management protocols. And for our audience members, thank you all for attending. We will have this recorded webinar available within the next few days on our website. And again, that certificate of attendance will be sent out by email here within the hour. And make sure, please, that you take some time to complete the survey that's also listed in our email link. So otherwise, thank you, everyone. Have a great day.